Welcome back to Beyond the Stethoscope, the podcast for general practitioners and GP registrars.
Hello again.
Today we're doing a deep dive specifically aimed at helping you prepare for those fellowship exams. We're tackling a really core topic, chronic heart failure.
That's right. A huge area for general practice and definitely high yield for exams. We'll be working primarily from the excellent chapter in John Murtaugh's General Practice, 8th edition.
And we'll also touch briefly on the historical side, looking back at William Withering's early work.
Gives perspective.
So our mission today is to really unpack chronic heart failure, the pathophysiology, those crucial index cases, management strategies, all from a GP perspective. We want to give you a really clear, comprehensive understanding.
Exactly. Not just reciting facts, but getting to grips with the why behind it all,
Yeah.
which is vital for both exams and, good clinical practice.
And it's quite fascinating to think William Withering, back in 1775, using Foxglove, or Digitalis, for dropsy. That was essentially early heart failure treatment. Shows how far we've come.
A very long journey indeed.
Okay, so let's start with the basics. Chronic heart failure. Fundamentally, what are we talking about?
Well, in essence, it's the heart's failure, its inability to pump enough blood to meet the body's metabolic demands. That's both when the person's resting and when they're active.
And it's not a benign condition, is it?
Far from it. It's serious. The chapter really stresses the poor prognosis, quoting something like 50% mortality within 3 years of the first hospital admission.
That's sobering. Really highlights the need for effective management in primary care.
Absolutely. And we see a lot of it. The prevalence is around 1.5% in adults overall, but it climbs steeply with age.
Right, I remember seeing those figures.
Yeah, it's about 1% in the 50-59 age group, jumps to over 5% for those over 65, and then, well, it's over 50% in people 85 and older.
So with our aging population, this is something we're managing more and more.
Definitely. And Murtaugh points out something interesting for us here in Australia, potential undertreatment of systolic heart failure with ACE inhibitors. Something to keep front of mind.
A key practice point right there. So, boiling it down, the pathophysiology revolves around two main problems.
Correct. Fluid retention, causing congestion, and a reduction in cardiac output, meaning the heart just isn't pumping effectively enough.
Okay, so when a patient presents, and we suspect CHF, diagnosis starts with the fundamentals, right? History and examination.
Always. Murtaugh emphasizes this heavily. Careful history, careful examination, they're paramount.
Let's talk symptoms. The classic one is breathlessness, dyspnoea on exertion. How does that typically unfold?
It tends to progress. Initially, it's just with significant exertion. Then, as things worsen, it becomes dyspnoea with less effort, eventually even at rest.
And then comes orthopnoea.
Exactly.
Yeah.
Breathlessness when lying flat, needing pillows to prop themselves up. And then paroxysmal nocturnal dyspnoea, or PND, that terrifying waking up at night gasping for breath.
Real red flags, those.
Absolutely.
Beyond breathlessness, what other symptoms point towards that fluid accumulation aspect?
Well, you've got the dyspnoea and orthopnoea. Then there's often a dry, irritating cough, sometimes worse at night.
Which we need to differentiate from other causes.
Precisely. Could it be asthma, bronchitis,
Mm-hmm.
or even an ACE inhibitor cough? We need to consider those.
Yeah.
Also, general lethargy and fatigue are very common.
Mm-hmm.
Noticeable weight changes, usually a gain from the fluid,
Mm-hmm.
swollen ankles, that peripheral edema, and sometimes abdominal discomfort, sort of a fullness due to liver congestion.
And then the symptoms reflecting poor cardiac output.
Right, that's things like feeling dizzy, lightheaded, maybe even syncopal episodes, fainting. And again, that profound weakness and fatigue, it all ties back to the heart not pumping efficiently.
Okay, moving on to examination.
Yeah.
What are the signs we're looking for? Murtaugh helpfully splits them into left and right heart failure signs.
Yes, which is a useful way to think about it. For left heart failure, you might find tachycardia, a fast heart rate. The pulse might feel weak, low volume. Murtaugh even mentions pulse pressure less than 25 mmHg as potentially significant. Tachypnoea, so breathing faster. When you feel the chest, the apex beat might be displaced outwards laterally.
Right.
Listening to the lungs, you'll often hear bilateral basal crackles. And listening to the heart, you might pick up a third heart sound, an S3 gallop, that indicates high filling pressures.
Mm-hmm.
In more severe cases, pleural effusions. And generally, signs of poor peripheral perfusion, cool peripheries, maybe pale skin.
And for right heart failure, what are the key signs there?
Think venous congestion. So an elevated jugular venous pressure, the JVP, is classic. Check the neck veins. You might feel a right ventricular heave when palpating the chest.
Okay.
Peripheral edema is very common, ankle swelling, pitting edema. And as it gets worse, hepatomegaly, an enlarged liver, and even ascites, fluid in the abdomen.
And you mentioned auscultation earlier, listening carefully.
Crucial. Listen for those crackles in the lungs. Listen for the S3 heart sound, and listen carefully for any murmurs that might suggest underlying valvular disease contributing to the failure.
No, a really fundamental concept for exams and management is the difference between systolic and diastolic heart failure. Can you break that down?
Yes, absolutely essential. So systolic heart failure, often called HFrEF, heart failure with reduced ejection fraction. This is the one most people think of. The problem is the pump itself. The heart muscle can't contract forcefully enough.
So the squeeze is weak.
Exactly. The left ventricle is often dilated, weakened. The ejection fraction, the percentage of blood pumped out with each beat, is reduced, typically less than 40%.
And the most common cause?
Ischemic heart disease, by far.
Post-MI damage is the big one here.
Okay. And diastolic heart failure, HFpEF.
Heart failure with preserved ejection fraction. Here, the contraction, the squeeze, might actually be normal or near normal LVEF, usually over 50%. The problem is with filling.
How so?
The left ventricle is often stiff, maybe thickened. It can't relax properly to fill with blood between beats. So even though the pump function looks okay on the EF, it can't fill adequately, leading to backup and heart failure symptoms. Right, so it's a filling problem, not a pumping problem per se. Who typically gets HFpEF?
It's much more common in the elderly, particularly elderly women, often associated with long-standing hypertension. Interestingly, the heart size on chest X-ray might even be normal.
Despite preserved EF, they still have issues.
Oh, yes. BNP levels can be raised, just like in HFrEF. And crucially, the mortality rates are actually pretty similar to HFrEF. It's not a benign condition just because the EF is preserved.
And treatment differs significantly.
It does. This is key for us. Those cornerstone drugs for HFrEF, ACE inhibitors, ARBs, beta blockers, they haven't shown the same clear mortality benefit in HFpEF.
So what's the focus for HFpEF management?
It's much more about aggressively managing the underlying comorbidities, hypertension, diabetes, AFib, and carefully managing fluid overload symptoms with diuretics.
Got it. And Murtaugh mentions patients can have both.
Yes, a mixed picture is definitely possible, which adds another layer of complexity.
Underscores the need for echo. Let's circle back to edema. We see it often. How do we assess it properly?
It typically starts peripherally, lower legs, ankles. Pitting oedema. You assess it by pressing firmly with your thumb, say over the shin or behind the medial malleolus, for 5–10 seconds.
And look for the pit.
Exactly. See if an indentation remains after you release pressure. Note how deep it is, how quickly it refills. As heart failure worsens, the edema ascends up the legs, thighs, sometimes the abdominal wall. In bedbound patients, look for it over the sacrum.
Location and extent tell us about severity. Speaking of which, how do we quantify heart failure severity? Murtaugh mentions 3 angles.
Yeah, you can think about symptom severity, the degree of actual cardiac dysfunction like the LVEF, and the severity of the congestion, fluid overload.
But for practical classification,
The New York Heart Association, the NYHA classification, is the standard. Really useful clinically and for exams. It categorizes patients based on their functional limitation.
can you quickly run through the classes for us?
Sure, Class 1. Heart disease present, but no limitation of ordinary physical activity. Symptoms don't occur with normal exertion. 1-year mortality is relatively low, maybe around 5%. It's okay. Class 2. Slight limitation. Comfortable at rest, but ordinary activity causes symptoms fatigue, palpitations, dyspnoea. Mortality about 10% at 1 year.
Class 3.
Marked limitation. Still okay at rest, but less than ordinary activity like just walking across a room causes symptoms. Mortality jumps to around 20% at 1 year.
And Class 4.
Severe limitation. Unable to carry out any physical activity without symptoms. Symptoms might even be present at rest. Prognosis is poor here. 1-year mortality around 50%.
That NYHA scale is really valuable for gauging impact and prognosis. Right, let's get stuck into the causes, the index cases. Murtaugh lists quite a few, separating them for HFrEF and HFpEF. Let's tackle systolic failure, HFrEF first.
Okay. As we said, ischemic heart disease is the big one. Previous MI, significant coronary disease accounts for maybe 2/3 of cases.
The major player. What else is common?
Essential hypertension. Chronic, poorly controlled high blood pressure puts immense strain on the left ventricle over time, leading to hypertrophy, then eventual dilatation and failure. These two, IHD and hypertension, are the heavy hitters.
Got it. What are some other key causes of systolic failure?
Valvular heart disease is important. Things like aortic stenosis, aortic regurgitation, mitral regurgitation. They cause either pressure or volume overload on the ventricle, leading to dysfunction over time.
Okay.
Then you have high output states. Conditions where the body demands unusually high blood flow, severe anemia, hyperthyroidism, Paget's disease of bone, the heart works overtime and can eventually fail.
Right.
Non-ischemic, idiopathic, dilated cardiomyopathy, basically. The ventricle dilates and weakens, but we don't know why after investigation. Viral myocarditis inflammation from a virus can cause lasting damage.
Uh-huh.
And alcoholic cardiomyopathy. Alcohol is directly toxic to heart muscle. Important cause to consider.
That covers quite a few. Any others listed?
Yes, other cardiomyopathies like diabetic or familial ones. Persistent arrhythmias, especially poorly controlled atrial fibrillation, can cause tachycardiomyopathy and systolic failure. Certain systemic illnesses can affect the heart's arteriodosis, SLE, scleroderma, even severe hypothyroidism or myxoedema. Some chemotherapy agents are cardiotoxic. And then there's peripartum cardiomyopathy occurring around pregnancy.
A really broad differential. Emphasizes the importance of a thorough workup. Now, shifting to diastolic failure, HFpEF. What are the main drivers here?
Here, remember, it's about impaired filling, often due to stiffness. Key risk factors are long-term obesity, chronic hypertension, and diabetes. They all contribute to that ventricular stiffness and impaired relaxation.
So the metabolic syndrome cluster is implicated?
Very much so. There seems to be a familial link sometimes too,
Yeah.
and it's definitely more common in older women.
What specific conditions lead to HFpEF?
Well, ischemic heart disease can contribute, even without causing a major drop in EF. Systemic hypertension itself is a major cause, leading to that hypertrophy and stiffness. Aortic stenosis increases the pressure load. Atrial fibrillation impairs diastolic filling time. Hypertrophic cardiomyopathy, where the muscle is inherently thick, and pericardial disease, constricting the heart and limiting filling. Often, it's a combination of these factors.
So identifying the underlying cause is vital for both types, driving management. Let's move on to investigations. What's the absolute key test?
Echocardiography, no question. A transthoracic echo is the investigation of choice.
Why is it so crucial?
It gives us so much information. Ventricular size, wall thickness, chamber size. Crucially, it measures the left ventricular ejection fraction, the LVEF, which tells us if we're dealing with HFrEF or HFpEF.
Okay.
It assesses both systolic and diastolic function. Looks at valve structure and function, can pick up pericardial effusions, structural abnormalities. It's the cornerstone for diagnosis and assessing function.
A detailed look inside. What other investigations are standard?
ECG is essential, cheap, readily available. Look for signs of old MIQ waves, left ventricular hypertrophy, conduction delays like bundle branch block, arrhythmias like AFib.
And chest x-ray.
Still very useful. Might show cardiomegaly and enlarged heart. Signs of pulmonary congestion, interstitial edema, upper lobe diversion, fluid in the fissures, perihilar haze, curly B lines, maybe pleural effusions, or even frank pulmonary edema.
But a normal CXR doesn't rule it out.
Absolutely not. Especially in early stages or HFpEF, the CXR can be normal. Spirometry or a lung function test can be helpful if coexisting lung disease is suspected.
And blood tests. BNP comes up a lot.
Yes, B-type natriuretic peptide, or NT-proBNP. These are released when the ventricle is stretched. High levels strongly suggest heart failure and can correlate with severity and prognosis. Very useful biomarker.
What other bloods should we routinely do?
Full blood count check for anemia. Electrolytes crucial for monitoring, especially potassium and sodium, given the disease in the drugs. Kidney function, urea, creatinine, EGFR, essential baseline and monitoring, particularly with ACE inhibitors and diuretics. Liver function tests can be deranged due to liver congestion. Urinalysis. And definitely thyroid function tests rule out thyroid disease as a mimic or contributor, especially for AFib. Viral studies only if myocarditis is strongly suspected.
So a good baseline set to cover contributing factors and monitor treatment. What about more specialized cardiac tests?
These are usually under specialist guidance. Things like coronary angiography or CT angio to look for IHD, cardiac MRI for detailed missile assessment, hemodynamic studies via cath lab, endomyocardial biopsy rarely done, but sometimes for specific cardiomyopathies. Nuclear scans. These are usually second line.
Right, specialist territory. Okay, let's talk treatment. Murtaugh stresses a multidisciplinary approach.
Hugely important. It's not just about drugs. It involves treating the cause, removing precipitants, patient education, non-drug measures, and the right medications. Needs a team GP, cardiologists, nurses, dietitians.
Given the prognosis, prevention must be key. What does Murtaugh highlight for primary prevention in general practice?
Lots we can do. Good dietary advice, healthy weight, nutrition. Smoking cessation is paramount. Moderate alcohol intake. Strict blood pressure control. Manage lipids. early detection and tight control of diabetes,
Hmm.
early intervention after MI to limit damage, good secondary prevention post-MI beta blockers, ACE inhibitors, statins, aspirin, and timely valve surgery or intervention if needed. Aggressive risk factor management, basically.
So the bread and butter of good primary care. Once HF is established, what about treating causes and precipitating factors?
First step, as always, can we find a reversible cause or trigger? Identify and manage arrhythmias like rapid AFib.
Okay.
A correct electrolyte imbalances, especially potassium. Treat anemia. Address any active ischemia.
Right.
Move for dietary indiscretion, salt or fluid overload. Review medications carefully. Murtaugh's table 76.2 is great here, listing drugs like NSAIDs, some calcium channel blockers that worsen HF.
Very useful table.
Treat infections promptly, pneumonia, UTIs, check thyroid status again, address non-adherence to meds or lifestyle advice, ask about alcohol, even consider complementary medicines that might interfere.
A thorough detective work is needed. Now, the general non-pharmacological advice we give patients, what's crucial?
Education and support are number one. Patients need to understand their condition and treatment. Smoking cessation, again, vital. Cardiac rehab programs are excellent exercise, education, support.
Okay.
Encourage regular, moderate activity within limits, but also advise rest during exacerbations. Weight reduction if overweight. Dietary advice is key, specifically salt restriction.
What level of salt restriction?
Generally, no added salt, aiming for less than 2 grams or maybe 100 millimole of sodium per day. A dietitian referral is often very helpful here.
And fluid restriction.
Usually only needed in more advanced HF, especially if they become hyponatremic, low sodium.
Right.
Then maybe 1.5 to 2 liters per day, sometimes less. Limit caffeine and alcohol.
Okay.
Teach daily weighing. A sudden gain, like 2 kilos in 2-3 days, signals fluid retention and needs attention. Point them to resources like Heart Online.
Simple but effective self-monitoring. Any other general measures?
Yep. Keep optimizing all cardiovascular risk factors. Screen for and manage depression anxiety, very common. Regular follow-up is essential. Vaccinations, flu annually, pneumococcus every 5 years,
Right.
periodic echo checks,
Yeah.
maybe every 1-2 years if stable. Consider treating sleep apnea if present. It can impact HF.
Okay, let's dive into the drug therapy for HFR-EF systolic dysfunction, the evidence-based big guns.
Right. After treating underlying causes, the focus is on drugs proven to improve survival and reduce hospitalizations. The cornerstones are ACE inhibitors, or ARBs if ACE intolerant, beta blockers, specific ones, and mineralocorticoid receptor antagonists, MRAs, like spironolactone.
And digoxin.
Still has a role, mainly for rate control and AFib, or sometimes for symptoms and sinus rhythm if other agents aren't enough or tolerated. Maintaining normal potassium is also vital throughout.
Let's take ACE inhibitors first. Why are they so fundamental in HFR-EF?
They directly target the harmful neurohormonal activation, the RAS system. By blocking angiotensin II, they cause vasodilation, reduce preload and afterload, lessen the heart's workload. Proven mortality and morbidity benefits.
How do we use them?
Start low, go slow, but aim for the highest tolerated dose. That's where the best outcomes are seen. Murtaugh suggests maybe first dose at night to minimize postural hypotension risk, especially in the elderly or volume depleted.
And if they get the cough?
Switch to an ARB.
Yeah.
Similar benefits, much lower risk of cough. Often, initial therapy is ACE inhibitor plus a diuretic for fluid overload. Maybe hold the diuretic for 24 hours before starting the ACE to reduce hypotension risk.
Caution needed with potassium.
Definitely. Especially if combined with potassium-sparing diuretics or MRAs. Regular monitoring of renal function and potassium is non-negotiable with ACEs and ARBs. Table 76.3 in Naruto gives specific drugs and doses, very handy.
A great practical resource. What about diuretics? When and how?
Primarily for symptom relief from fluid overload breathlessness, oedema, usually added to an ACE ARB. Use moderately, avoid excessively high doses of one agent, if possible, to minimize side effects like electrolyte disturbance or renal issues.
And not as monotherapy in HFR-EF.
No, never. They relieve symptoms but don't have the mortality benefit of ACEs or beta blockers in HFR-EF. Monitor weight, renal function, electrolytes closely. Loop diuretics like furosemide are more potent, often needed for significant fluid retention. Thiazides can be used for milder fluid overload or sometimes added to loose and resistant cases.
Okay. And the aldosterone antagonists, spironolactone, epirorinin.
These MRAs offer additional benefit on top of ACEs and beta blockers for patients who remain symptomatic. They block aldosterone, reducing sodium water retention and potentially myocardial fibrosis, proven to further cut mortality and hospitalizations in specific HFR-EF groups.
Key monitoring point here.
Potassium, potassium, potassium. Big risk of hyperkalemia, especially combined with ACE-ARBs. Monitor very closely. Epinephrine is more selective, less risk of gynecomastia than spironolactone.
Beta blockers, also cornerstone now. Which ones and how?
Yes, specific evidence-based ones.
Nice.
Bisoprolol, carvedilol, metoprolol, succinate, long-acting. Proven to prolong survival in stable euvolemic patients with mild to moderate HFrEF already on an ACE inhibitor.
How do we start them?
Crucially, start very low dose and titrate up very slowly over weeks to months, aiming for the target doses used in the trials. Cable 76.4 in Murtaugh has these doses. Initiate only when the patient is stable and not fluid overloaded.
Okay.
Avoid inacute decompensation. Monitor closely during up titration as they can transiently worsen symptoms initially.
What about digoxin's current role?
More limited now.
Yeah.
Main uses: rate control and AFib with rapid ventricular response, and sometimes added for symptom control in sinus rhythm patients already on optimal ACE beta blocker MRA therapy who are still struggling. Use low doses. Watch for toxicity.
Murtaugh mentions newer agents too.
Yes, the field moves on. Ibogaine slows heart rate directly at the sinus node. Can be used in specific patients in sinus rhythm with elevated heart rate despite max beta blocker or if beta blocker is contraindicated.
Tenentristo.
Sacubitril/valsartan, yes, an ARNI angiotensin receptor neprilysin inhibitor, shown to be superior to ACE inhibitors in reducing death and hospitalization in symptomatic HFrEF patients, often considered as a switch from an ACE inhibitor in suitable patients.
For patients not responding well, there's a stepwise approach.
Yes, start ACE plus diuretic, add MRA, spiropolyuritic arenin, if still symptomatic fluid overloaded. Once stable and euvolemic, initiate and slowly titrate beta blocker. Consider digoxin for ongoing symptoms or AFib rate control.
And if they're still struggling, severe HF.
Seek specialist advice. Consider hospitalization. Might involve higher doses of ACE, loops, MRAs, maybe add a thiazide to the loop diuretic. Consider higher MRA doses, monitor K+. Optimize beta blocker, digoxin, maybe heparin if severe congestion immobile.
Other vasodilators.
Isosorbide dinitrate plus hydralazine is an option, especially for those intolerant of ACE-ARB, though evidence less strong. Nitrate patches can help symptomatically sometimes. End-stage options like transplant or LVADs are for specialist centers.
A clear escalation pathway for HFrEF. Now, quickly revisiting HFpEF management, what's the approach there?
Different focus. Primarily treat underlying causes: hypertension, ischemia, diabetes. Control comorbidities aggressively. For symptoms, diuretics are used carefully for fluid overload.
What about drugs affecting heart rate or relaxation?
Murtaugh mentions calcium channel blockers like verapamil-diltiazem, or beta blockers can be used to improve diastolic filling time and control rate, but caution advised with diuretics, risk of dropping preload too much, and generally avoid digoxin, nitrates, nifedipine if possible. ACE inhibitors can be used cautiously, mainly for BP control.
Much less clear evidence base for specific drug benefits in HFpEF.
Yeah.
Murtaugh lists some common management pitfalls we should avoid.
Yes, important reminders. Excessive diuretic use leading to dehydration renal issues, or the opposite, inadequate diuretic use. Too high an initial ACE inhibitor dose causing hypotension.
Okay.
Critically, failing to identify and treat remedial causes or precipitants. Failing to get that crucial echo to confirm diagnosis and measure LVEF, and failing to monitor electrolytes and renal function regularly.
All key clinical pearls. What about acute severe heart failure?
Murtaugh refers to Chapter 120 for detailed management of acute pulmonary edema. That's a separate urgent protocol.
And device therapies. Briefly.
Increasingly important for selected patients. ICDs for preventing sudden death from arrhythmia. CRT, or biventricular pacing, for specific patients with HFrEF and LBBB to improve synchrony, and LVADs as bridge to transplant or destination therapy. Specialist territory, costly infection risks.
As GPs, when should we definitely be referring to a specialist?
Good guidelines in the chapter. Younger patients, say 65. Diagnostic uncertainty, especially suspected HFpEF. Complex management difficulty titrating meds, multiple comorbidities. Suspected familial cause needing screening.
Also.
Any acute decompensation needing hospitalization. Refractory symptoms despite optimal therapy. And consideration for devices or transplants. Basically, it's unsure, complex, severe, or young, refer.
Very helpful criteria. Murtaugh ends with some key practice tips. Can you summarize the absolute highlights?
Sure. ECHO is gold standard for diagnosis and LVEF. Early diagnosis and optimal therapy are vital. Use a multidisciplinary team. Refer early. ACE inhibitors, or ARBs, for almost all HFrEF patients, the main reason is reducing death hospitalization risk. Diuretics are for fluid overload symptoms. Use with ACE beta blocker in HFrEF. Aim for ACE inhibitor and beta blocker in HFrEF if possible. Beware hyperkalemia with ACE-ARB plus MRA combo. Device therapy is expanding for selected patients.
Excellent summary. And resources for patients.
Murtaugh's patient education has a handout sheet, and the Heart Online website is a great resource for patients and us.
This has been incredibly thorough. A really deep dive into chronic heart failure, covering so much ground relevant for general practice and, crucially, for fellowship exam preparation. Just to quickly recap the absolute must-knows.
We've covered the definition, the seriousness, the prevalence, diagnosis through history, examination, key signs and symptoms, the vital difference between HFrEF and HFpEF pathophysiology, causes, management, investigations, especially echo and BNP.
And the comprehensive management, prevention, non-drug measures, the detailed drug therapy for HFrDF focusing on ACEs, beta blockers, MRAs, the different approach for HFpEF, pitfalls, referral criteria, devices.
It really highlights the need for an integrated approach, considering the whole patient and working collaboratively.
For those of you studying, really try to consolidate this. Think about the pathways, the drug classes, the reasons behind the recommendations. Go back to the Murdaugh chapter. Use resources like Heart Online. Discuss cases with peers and supervisors.
Absolutely. Reflect on how this applies to patients you've seen or cases you're reviewing. Where are the complexities? What are the key decision points?
We genuinely hope this deep dive has been useful for your clinical practice and your exam revision. We always want to cover topics that are relevant and helpful for you.
Yes, please do let us know if you have suggestions for future topics you'd like us to tackle. Your feedback helps shape these sessions.
Thank you so much for joining us on Beyond the Stethoscope, the podcast for general practitioners.
Thanks for listening.